Good afternoon, everyone, and thank you so much for joining us on this session of the Patient Support Group meeting for ISBMT. My colleague, Dr. Venkatesh, he has some problems with connectivity. So, on his behalf, I'm welcoming everyone to this support group meeting. The support group meetings were ideated by the ISBMT, and this particular one is on transfusion support. So, in and around the transplant time, patients need a lot of red blood cells, sometimes granulocytes, sometimes platelets. So, what can we do to help them? What are the products? And how do we find ideal donors? So, this is a very interesting and useful sessions. And I want to thank the sponsors Genova and Novartis for always supporting the educational activities. And I'd like to start off today's session, please, by welcoming our speaker. So if you can go to the speaker slide, please. Um, it's really my pleasure to invite Dr. Rizwan Javed. He is a transfusion medicine specialist at the Tata Medical Center in Kolkata, and an amazing person, and has done a lot of work on standards for transplant units and also in the area of apheresis, and he's going to talk to us about this very important topic today. Over to you, Rizwan Javed.
Thank you, ma'am. Thanks for the such a kind introduction, and thank you for the opportunity as well to speak to this gathering comprising of patients, and I see many medical professionals as well. So it will be a pleasure to talk about the transfusion support in bone marrow transplant. I hope my slides are visible. If it is so, then I can just proceed.
Yes, please proceed, sir.
Yeah. So in the next 20 minutes, so I'll just minimize this. Yes. So in the next 20 minutes, I'll quickly give an overview of what transplant is all about and where the transfusion medicine's role is in terms of a successful transplant, which starts right before admission of the transplant patient, managing the transfusion support as well as reactions and even prevention during the entire course, and taking it forward and the post-transplant period as well. So when we talk about an overview, many of us know that right when the transplant patient lands up in the BMT OPD, there we start not only with the recipient but donor evaluation as well. And during that phase itself, a pre-transplant transfusion assessment should be ideally done, which not only comprises of doing the ABO grouping and the RH typing, but looking for any alloantibodies if there are any. And this is the very crucial moment where even the transfusion medicine specialists gets to be introduced to the patient and their family, because that's when the sensitization of as to how many donors they have to get and when they have to get. So this pre-transplant transfusion assessment is very crucial, even before when the donor is being mobilized. And then when it comes to peripheral blood stem cell collection itself, the transfusion team takes the lead there. In case if the product is to be transfused fresh, it goes into the recipient. Otherwise, it needs many times for logistic and other reasons. It has to be processed further and most commonly cryopreserved. Thereafter, it's administered to the recipient who would have already undergone a conditioning chemotherapy by then. And not all, but few odd patients may require transfusion support even before or during the time of conditioning chemotherapy. But definitely post-transplant, transfusion support is intense, and it's key for a successful engraftment. And engraftment is the terminology we use when the patient's body and the hematopoietic system is able to manufacture all the blood components, be it the red cells, the platelets, on its own without any external transfusion support. And this engraftment is subsequently leads to a group change in case if there's an ABO mismatch transplant. But in cases like autologous as well as same group, we are not looking for a group change. And that's when I would like to give a snapshot that in an autologous transplant, the requirements are fairly less. So much so that in all transplant, they say there would be almost all transplant patients would have a 90% requirement of red cells, but almost all 100% requirement of platelets. So that is the type of transfusion support we need, that almost every patient will invariably require blood transfusion of blood products. And having said that, when it comes to allogenic transplants are again two types, matched and with unmatched. It could be a full matched. And when we don't have a full match, the transfusion requirement is more in haploidentical settings. So anybody who is matched 8 by 10 or less would be haploidentical, not necessarily half matched with the donor's HLA. So the transfusion requirement, I've just colored it in the traffic signal mode. In autologous is fairly less. And as we go into an allogenic haploidentical transplant, the requirements would be immense. Before we dive into the details of the transfusion support, I thought I'll put this slide to emphasize the different phases of transplant. And to make it more simple, I would try the audience to understand that the first phase of transplant starts with the conditioning. I'm trying to draw comparisons as to how we do probably farming, where we have to till the soil and plow the soil. So and that is a harsh place where you use instruments, and then the patient undergoes chemotherapy and radiotherapy, which is basically trying to get rid of everything which is there in the marrow. So you're literally weeding out everything. And some patients do require transplant who had transfusion support in this phase, but definitely in the next phase, which is called the aplastic phase. Now, after the plowing has been done, the hematopoietic stem cells, which are like seeds, have been put up in the soil, and we start watering. Now, that's the intensive transfusion support which is required, where the patient is undergoing a cytopenia, and it takes a while before these hematopoietic stem cell seeds begin to engraft. Now, engraftment is a phase where exactly some roots would come out. There would be a stem cell recovery, and it takes roughly a week or two, depending upon the type of transplant we are doing. So in an autologous scenario, the transfusion support until engraftment would be roughly around a week to 10 days. Whereas in allogenic matched, it could go in for 2.5 weeks. And in haplo and others, it could be 3 weeks as well. So in that case, the engraftment process, the transfusion support for all the bloodlines, including red cell, platelets, and WBCs, may be required. And engraftment, post-engraftment, when the sapling starts fruiting, that's a post-engraftment, and that's when the patient goes home, because the transfusion requirements would be low or probably minimal, because most of the times when patients are discharged, they would have engrafted the neutrophils. So neutrophil engraftment is there. The red splats will be stable, and some patients may continue to require platelets even post-discharge. So in each phase, it's crucial to understand the unique transfusion needs and the distinct challenges the clinical team would face when it comes to the management. And here I've just put up a table as to show how differently at different time points the neutrophil and platelet engraftment takes place. And as always, not necessarily the patient is admitted for platelet engraftment. And in this entire picture of intensive transplant phase, the role of a transfusion medicine specialist is very crucial, because they play as an interface between the transplant team and the blood center. And in centers like ours, where we have a robust transfusion medicine support, we make sure we are able to cater to the bedside needs of our transplant patients. So we have a continuous monitoring of day-to-day transfusion needs based on our established transfusion policies, compatibility protocols, training the staff in managing reactions and dealing with traceability issues, ensuring even quality and regulatory compliances when it comes to transfusion needs of the transplant unit. But however, as I initially mentioned in my initial slide about pre-transplant grouping and typing. Now, since there's a patient group involved, I thought I'll put up this lucid presentation and slide to make them understand what is an antigen and an antibody. So basically, we know there are so many types of blood groups. And if I have to just make it more simple, if you remember the ABO blood group system itself, so if you are A, B, or O, each red cell has got a surface protein or glycolipid. Now that could be, and that is called the antigen. Now, if somebody has got A type, the blue dots, as you can see on the red cell, is the A blood group. And if it is B type, it's B. And when they are both present, it's called AB. And when they are none, it becomes O. So the red cell is free of any bullets that you can see on the red cell surface. Now, whenever we have an antigen, the corresponding antibody is naturally present. The corresponding antibody is absent, is the opposite one which is present. So if an A antigen is present on the surface, the plasma, so our blood, basically, if you spin it, it would have the red cells, it would have WBCs and the plasma. So in the plasma, we would have these antibodies. Now, naturally, the B would be present in an individual who has got an A antigen on the red cell surface. For a B individual, the plasma would have anti-A. And in O, there would be two antibodies because the red cell surface has no antigen. So that's how they thrive. And there's always a problem if you have an antigen and antibody for the same type present in the blood. So which is when we do not want it. And how do we test for them? In the blood center, we do a blood grouping. So all of us know about our blood groups and we proudly say whether we are A positive and B positive. So when it comes to the ABO system, we would do a forward typing where we'd only figure out what the antigen is there on the surface. And simultaneously, we would do a reverse typing and try to find out which antibody is present in the plasma. And when both actually correspond, that's when we confirm and give the grouping as an ABO. Now, as we talk, I would like to tell, for all simple reason, we only type two common blood group systems, that is the ABO and RH, capital D. But there are actually 48 blood group systems, so which is practically impossible and neither cost effective to test all of them. So we test the most immunogenic or the most problematic ones, I would say, which is the ABO and the RH blood group system. And to be always sure that we have done the grouping correctly, they are at least done twice before taking up the patient for transplant at different time points. And there are different methods. I've just put up this gel card method, which we do at an institute to figure out the blood group systems in the forward and in the reverse typing. And apart from that, as I told, there are so many other blood group systems. So at times when the transplant patient is undergoing a transplant, some centers would have the logistics as well as the capacity to do an extended blood group system where we try to figure out some more important, significant blood group system. It is not mandatory, but it is depending upon the infrastructure and logistics. In the extended typing, the other RH factors could be found out apart from Kell, Duffy, and Kidd. And centers in the West go a step further, doing some other systems like Domrock and LU systems. This is just to sensitize you to the fact that there's much more than just ABO blood group system. When we talk about the RH blood group system, it's fairly simple. The word RH comes from the rhesus, which is a monkey. So it's either present on the red cell surface or it's absent. When it's absent, it's called the RH negative. And why do we do a blood group system even before transplant? It's just to figure out what are the antigens already on the red cell surface, what are the antibodies in the plasma, because most of the times these patients, be it like aplastic anemia or myelodysplastic, their patients have been treated for months and sometimes even years before they come in for a transplant. They would have received so many blood transfusions from different centers altogether. And they might develop antibodies, additional antibodies other than what the initial blood group was. So to resolve all cross-match discrepancy, identify any other antibodies, and even drug-related interference to our blood groupings. For instance, multiple myeloma patients very often receive daratumumab. Now, these drugs can also interfere with blood grouping. So it's important and critical for the blood center to know exactly the blood group and the status before transplant. And why it is important is because if the blood center or the transplant unit is unaware of it and unaware of these alloantibodies. Alloantibodies, I'll explain what it means later. But these alloantibodies they are additional antibodies which could complicate transfusions. And what are these alloantibodies? These alloantibodies are body has a unique system of producing antibodies against foreign antigens. So if any patient is exposed to any blood unit or any intervention, he or she may develop additional antibodies towards the different blood group systems that we have mentioned. And these blood group antibodies always interfere and cause transfusion reactions, interfering with the cross-matching. So it makes the cross-matching difficult, and finding a compatible blood unit from the blood center becomes a tricky job. So with these problems, multi-transfused patients are always at a risk of developing alloimmunization. And the best way to avoid or minimize this would be remove processes which the blood center follows of leukoreduction and trying to match the antigens, which I shall elaborate subsequently. But alloimmunized patients invariably may also require a lot of transfusion. And it's important to understand what are the common blood donor criteria, because patients who are undergoing transplant and their families should be aware of the fact that it's just not 1, 2, 3, or 4 that would be sufficient. So many a times you need at least a dozen and more of donors to get units. However, it again depends upon the transplant, which I shall discuss in my later slide. But what is important for them to know when they go out into the community to get donors, because blood centers try their best to do donor recruitments, but the need is so enormous that they themselves may not be sufficient to do this job. And that's when we seek help from patients, friends, and families. And it's important that any donor who comes to for donation is legally able to donate, and it's in the age group of 18 to 65, with having a minimum weight of at least 45 kgs and a hemoglobin of 12.5. With having a blood pressure, he should be fit and fine, not suffering from any disease, as in if it is controlled hypertension or controlled diabetes, it's perfectly okay. But it's not okay to have fever or any existing influenza or infection or malaria. So they should be fit enough to walk into a blood center without having a recent history of at least 4 weeks of be it a surgery or even a dental extraction for that matter. In the blood center, under confidentiality, we do find out signs of high-risk behavior. And in case of females, they should be non-pregnant and non-lactating. And donors should have had at least a meal or a light breakfast before they come in. So broadly, not being a sexist here, but usually young, healthy male donors are good contenders in case they are not taking any medicines. And donation frequency, men once in 3 months can donate whole blood, while as women once in 4 months. And at the blood center, we again try to do the transfusion associated infections, diseases. From every donor, we are actually able to make 3 blood products on a minimum side. As I've shown in my initial slide, we spin the blood. It will stratify into 3 components. The topmost is the plasma, which is a watery component, which has electrolytes, iron, and minerals, which becomes a plasma unit, which is frozen, and it's called the FFP popularly, the fresh frozen plasma. It also has the clotting factors and very useful when it comes to treating people who would be having bleeding. The second unit, right, very important in the bottom is the red cells. Now, the red cells are the ones which have the oxygen carrying capacity, and these red cells also push up the hemoglobin. Roughly one packed cells of red cells would push the hemoglobin by 1 unit. And between the 2 layers, there's a sandwich white cell or buffy coat layer, which helps us to make the platelet and a buffy coat, which I have not shown here because most of the time we may not necessarily use it until indicated by the clinical team. But platelets, which are called the random donor platelets, are made from this blood unit, which has been extracted from the donor. So the donor usually donates around 350 to 450 ml. Having said that, these 3 units, all cellular units, undergo an irradiation at the blood center, which is basically to inactivate the donor T cells. So there's a very popular myth that irradiation may cause many other things, but the primary reason why we do irradiation is to prevent graft versus host disease, which could be transfusion associated and because of donor T lymphocytes. So many a times we discourage patient and family members not to donate blood. But if a center has got an irradiation facilities, anybody can practically donate. When it comes to the other procedure that we do is leukoreduction, where we remove the WBCs from the blood products. And there are different methods of removing WBCs. One, it could be right at the time of collection before storing the blood, which is the best method. However, not all centers may have that facility. And in those cases, near the bedside, we put leukodepletion filters, which are put up, spiked into the blood unit. And by the latest technology that we have, almost 99.9% of the WBCs could be removed. And why is it important to remove the WBCs from the unit is because these WBCs are responsible for causing transfusion reactions like febrile reactions, which causes fever. At the same time, they could always cause cytomegalovirus infection transmission. So if WBCs are removed, the chances are minimized. At the same time, the chances of aluminization are also minimized by doing a leukoreduction. So these are the important advantages of having a leukoreduced product. The last one is basically a pathogen inactivation system. Now, this is the most sophisticated system, which is in most of the centers in India may not have it. It is just, I've put in here to emphasize that there's always a risk of transfusion transmitted infections from donors to our recipients. And this has to be minimized as much as possible, either by testing as per serological tests using chemoluminescence as advised, mandated by the government, or even going an extra layer of safety by doing nucleic acid testing, where we try to find out even if people are there in shorter window periods. And a pathogen in the inactivation system would actually be able to inactivate any virus for that matter in the product because the product is mixed with soralin, which is activated by passing UV lights. However, it dramatically increases the cost. So the cost of the product would go up by 3 times to have a system like this. The units, eventually, once they are prepared, the most commonly used units are the packed red cells. Now, the packed red cells are, as I've mentioned earlier, contains red cells, which are basically for the oxygen carrying capacity of the patient. It improves the hemoglobin by 1 grams, but we don't use it randomly. So to prevent aluminization, transfusion reactions, the discretion is applied to keep hemoglobin threshold of 7 to 8 grams per deciliter in a transplant patient. Only when the hemoglobin falls below 8 and sometimes even below 7, then this is used. And that's called the restrictive method of transfusion. Or the patient having symptomatic anemia, breathlessness, and stuff like that, if all other causes have been ruled out. And these units can actually are prepared from whole blood donors and can be stored for up to 35 days. With newer bags called the SAGM bags, which are the anticoagulant, they can be stored up even to 42 days. And they are stored at 2 to 8 degrees. Now, having mentioned this, it is important that many transplant centers may not have an active blood bank, and they are getting these blood components from centers outside or a third-party blood center. It's important to note the temperature for storage and transport. So if the storage temperature is exceeded, there are chances that the unit may not be the best working capacity and the cells will not be viable to work best. So it's important that even outside, because outside in the Indian conditions, the environment temperature is close to 35, 30 degrees. So it has to be ice packed and transported in temperature controlled containers. At the same, coming down to platelets, I've mentioned about random donor platelets are the small packs which are produced from one whole blood donation. Now, since they are small in size, they will have less amount of platelets as well. And when do we give these platelets? These platelets are given whenever there's a thrombocytopenia. That means when the platelet count in the patient recipient is less than 10,000 per cubic millimeter, or when there's any bleeding at any count, irrespective of the count. So in cases where there's bleeding or very high risk of bleeding, or the patient is undergoing a procedure like central line placement or a biopsy, then the chances of bleeding increases. And that's why platelets are very crucial in stopping. They act like plugs and stop bleeding. Now, these platelets, however, do not last long. Their shelf life is only 5 days, irrespective of whether we add any other media or not. And they are not to be kept in stationary, because they always kept in special agitators where they keep moving. In case they are being transported, we cannot ask the attenders to continuously move, because I think the roads will allow us enough of gentle agitation that these units may require. And they are always transported at room temperature, as in 22 to 24 degrees, which is still much less than our environment temperature outside. So they have to be kept in some cold box, which is not as cold as 2 to 8. When it comes to plasma and cryoprecipitate, now cryoprecipitates are basically factors which have been prepared from the plasma and they have been frozen. The volume is very less and usually used for coagulopathy and replacement of fibrinogen. And these units are frozen at -80 for 1 year. Now, whenever they have to be transfused, they are thawed and they have to be transfused within an hour, or maximum, I would say within half an hour. The faster, the better. So in most of the scenarios, we say platelets and plasma products to be transfused ASAP or initiate within 15 minutes. If there is has to be an extension and a time limit, half an hour should be the max. Because of the clotting factors being lost, it will not be of great utility. The last, which I have earlier mentioned about the Buffy coat, which was also prepared at the same time when platelets were being prepared. Now, these Buffy coat are also called as granulocytes. Now, one method of these are not always used. In some conditions, when the patient is neutropenic and having fever for a very long time, these Buffy coats are actively asked for, and they are used of the same ABO compatible donor. And they are useful only within 24 hours of manufacturing and kept at 24 degrees without agitation. Having introduced you to all the blood components, the other method of making platelets as well as granulocytes is called apheresis. Now, apheresis is a procedure which helps us to prepare where the donor, there's one single donor who is connected to the apheresis machine, and by which we are able to collect one therapeutic dose of be it granulocytes or buffalo or platelets. And that is called the single donor platelets. The difference between the two platelets, the random donor, which is smaller in size, as you can see, the single donor, which is larger in size. And not only is the visible difference in the size, but also in the volume, the content. So it is said roughly 6 random donor platelets would be equivalent to the content of one single donor platelet. And since it is produced from one donor, the chances of aluminization are dramatically less. However, having said all this, the cost of the single donor platelet is also exponentially higher than a random donor platelet. So depending upon the center, the patient affordability, the units between the choice between single donor and random donor platelets are used. Something very crucial to understand is when it comes to single donor platelets, the donors have to be recruited. They should be more than 50 kgs, having at least 1.5 lakh of platelets. And these donors have to be tested before they are put on for the donation. So they're not, so until these units are readily available, they cannot be used. So random donor platelets, on the other hand, are readily available in most of the blood centers and could be used in emergency situations. Having said this, choosing the right blood product. Now, most of the times we request, so the patient party needs to know how many whole blood donors and how many SDP or single donor platelet donors required. Now, whole blood donors, since they can be stored for 42 days and 35 days by other anticoagulants, they can be got just before transplant and they can be stored. Now, ideally, as mentioned, a healthy donor who is free of most medications and is good to do should be eligible for donation. And when it talks about grouping, most of the time the blood bank is able to provide the right groups to our patients, even if they're not able to manage the donor as per the group compatibility. However, when it comes to negative blood groups, it is important that negative donors are brought because blood banks would not have an inventory of negative donor units. And many a times it becomes a challenge to provide negative units to patients.
Dr. Rizwan,
Yes.
may I request you to wrap up the talk quickly because
Sure.
we have to proceed with panel discussion.
Yeah, I'll just take 2 minutes and we'll wrap it up.
Sure, sure. Okay.
When it comes to platelet transfusion, in many centers, platelet transfusion thresholds have been set up. We do not transfuse patient in case if they are stable at 20,000. But if the count falls down to 10,000, then also platelet transfusion is mandatory. And in many times when patients have got antibodies against platelets, a compatible platelet unit is crucial, and that is when HLA matched or cross-matched platelet units are very effective. And for doing the cross-matching of platelets, to make it more economically viable, it is important for the patient family to get at least 5 to 8 donors at a time to do the cross-matching, because it will be more economical to do it then. The most complicated of all transplants are ABO incompatible transplant, where the donor and the recipient are of different blood groups. And when it comes to major ABO mismatches, the transfusion requirements and the risk of complications dramatically increase. And at every phase of transfusion, be it before or during or after transplant, we have to go through a chart to make sure that a compatible unit is issued to a patient. Many patients post-transplant, ABO incompatible, could also undergo complications like passenger lymphocyte syndrome, which is a delayed kind of hemolysis, and pure aplasia, where the transfusion requirement goes on up till 1 year. The requirements are normally, if I have to say how many donor units, this is from what we have been able to calculate in our patients. In autologous, the requirements are pretty less. But when it comes to haploidentical, there could be 7 whole blood donors and 4 to 5 platelet donors on a rough side. And with an ABO mismatch transplant, the requirement almost doubles up. Then we could have 10 to 15 is the median whole blood donors, and platelet donors are still around, SDP donors around 5 to 6. Transfusion reactions, which the nurses manage at bedside. What patients need to know is that any increase in temperature, wheezing, breathing difficulty, palpitation, you should be reporting immediately during the transfusion itself so that the nurses can raise an alert and support can be provided to you and managed at the same time. Post-transplant donors, the BMT donors are hematopoietic stem cell donors, could also be required for donor lymphocyte infusion when there is a impending graft failure or a poor graft function with a CD34 boost, and even matched platelets if there are no other better donors. So at the end of it all, I will just sum it up by mentioning that when it comes to transfusion support in transplant, it is very individualized, safe, and coordinated. Support is based on the conditioning, the patient age, sex, and the type of ABO mismatch. So there are no fixed rules. And depending upon the alloimmunization, post-transplant complications like infections and graft versus host disease often guide or rather tell us how badly the patient may require an increased transfusion. So a collaboration of all the units, hematologists, the transfusion specialists, nursing teams are best, can provide the best outcomes. I would finally end up with acknowledging my mentor and the grandfather of bone marrow transplants in the country, who actually helped up set this unit 13 years ago. And thankfully, it's been running the same fashion as it used to be. Thank you so much. I'm done.
Thank you so much, Dr. Rizwan. So that was a very lucid and comprehensive talk. I think all of our audience must have listened to it very nicely. And we should, I think in the interest of time, we should quickly proceed to the panel discussion. And I would like to invite our moderator for the panel discussion today, Ms. Renal, who is nurse in the BMT unit at one of the most prestigious centers, ACTREC, Tata, Mumbai. And as panelists, we have the pleasure of having today with us Mr. Neeraj Trivedi, who is the founder, director of BMT Support Foundation. Dr. Rizwan, you all have heard already. Mr. Srivatsa Vema, who is the founder of Platelet Club, Chennai. And Dr. Rasika Dhaban Setia, ma'am is director and head of Department of Transfusion Medicine at BLK Max Hospital, New Delhi. So over to you, Ms. Renan. And I would really request all the panelists to be please brief and to the point in the answers.
Thank you, Dr. Silky, for that introduction, and thank you to the ISBMT Patient Support Group for the opportunity. Let's start with the discussion without wasting any time. So the first question is to Dr. Rizwan. What is the role and importance of transfusion support for patients before BMT?
Yeah, thank you for the question. I have covered this, and what is important is before BMT, the patient blood grouping, ABO blood grouping, and RH typing is done. Antibody screening is performed, and we are able to even plan in case of what kind of transplant it is, whether ABO match or mismatch. And in case if there's a rare blood group or rare antibody or a negative blood group, the inventory management at the blood center is crucial for not only donor recruitment, but also counseling.
Thank you, sir, for that answer. Moving on to the next question. The question is to Dr. Rasika. What kind of transfusion support do patients typically require after HSCT and for how long?
Thank you so much. Yes, Dr. Rizwan has actually covered that very well in his talk. And what is important to note that the transfusion support is required, as Dr. Rizwan said, in the pre-transplant period also. And during the transplant period till engraftment, the support there is very crucial till the bone marrow, the transplanted bone marrow actually takes over. So during this time, you need to tide over the period of anemia and thrombocytopenia. The patient's marrow till it's ready to the donor marrow is ready to prepare platelets, the support will be required. Typically, the support is required for a period of 2 to 4 weeks. And if the patient does have some kind of infection, this requirement may go up. In case the transplant is going on smooth, there is less, there's not much mucositis or other problems, then the requirement is less. And in case some patients do have some infections and they are non-responsive to some of the antibiotics, they may even need granulocyte support. So these requirements are a part and parcel of the transplant, and that's when they're required.
Thank you, ma'am. The next question is to Mr. Neeraj Trivedi. So, from your experience, how aware are patients and families about the need of transfusion support post BMT?
So I'll answer this question from two perspectives. One is, so my transplant happened about 10 years ago, where the awareness was not much in terms of how much transfusion support is needed. But however, in today's time, I think there is a lot of awareness in the patients. The only problem here is the patients have not informed the community that they may need support. So, so had you gone to your corporates, your friends, your professional circles, all the other circles and informed them well in advance that there might be a requirement and we will come to you when we need support, I think it's much easier to kind of do it at that time. So we always tell the patients in advance is who is your closest community that you will reach out to in terms of transfusion needs. So they need to have a group of at least 40-50 people who they can reach out to immediately. So now I think the awareness is growing, but earlier the awareness was much less.
Thank you, sir, for your insight. Moving on to the next question. This is to Mr. Srivatsa Vema. Sir, how can the community support patients with the blood and platelet donations during BMT?
Thank you, everybody. This is Srivatsa Vema from Platelet Club NGO Chennai. Communities plays a major role, especially when patients undergoing a bone marrow transplant need a significant blood and platelet support, because the conditioning therapy and radiation can damage their bone marrow, halting their body ability to produce new blood cells. The community can offer vital support during a direct action, coordinated drives, and raising awareness like direct community actions like voluntary blood donors coming to donate platelets and frequent platelet transfusions gives new stem cells engraft and being producing enough of their own platelets. Direct donations also happens from patients, family and friends with a matching or compatible blood type. And community-wide campaigns like organized efforts will amplify impact and broaden the donor pool. Apart from that, you can also expand donor registries. So as far as platelet club is concerned, we maintain, for example, thalassemia cases, we keep donor dedicated donors, like we call it as DDR, dedicated donor registry. So every thalassemia kid who is visiting Chennai for transplant, blood transfusion, we keep sending those donors regularly, month on month, every 3 months. And volunteering and financial support. This plays a major role for patients who are undergoing BNT. So government people who are affordable, okay. All those who are not affordable, they go for banking, insurance, everything. And we do also support those kind of financial support beyond donating blood. Community members can contribute their time and resources and volunteer at blood center. Most of the blood banks and donor centers need volunteers to help their logistics, donor care, and recruitment efforts during donation drives. and also offer financial donations. Financial support can help offset the costs associated with donor registration and drive campaigns, and can support organizations dedicated to patient care and transplant research. Apart from that, patient practical support to patients, talking to them, interacting with families, need assistance with transport, food, meals, accommodations. All these are all plays a vital and intensive role on the recovery process. And community groups can organize to provide these direct and practical support as well. Thank
Uh,
you.
yeah, thank you, sir, for that wonderful answer and the good work that your NGO does. Moving on to the next question. This is to Dr. Rizwan. You've already covered it, sir, but very briefly, what type of blood components are most often required by patients post transplant?
Yeah, it depends upon the type of transplant again and what happens to the fate of the patient. So in case of a clean case where there are no complications, the transfusion support will be minimal. But however, the patient develops GVHD, is on drugs like ansoiclofir, you'll have cytopenias, and then you will require platelets as well as red cells. Patients having EBO incompatible transplant, the transfusion requirements for red cells would increase up to post-transplant to 1 year sometimes, which could be very difficult to manage. And in case, God forbid, the patient is not doing that great, goes to the ICU, he's neutropenic, not refractory to most antibiotics, then even buffy coats or granulocyte apheresis could be required by the patient. And FFP and cryotherapy in coagulopathy, which sets in difficult complications and other scenarios, the transfusion requirements are enormous and almost all units are used.
Thank you, sir. Moving on to the next question. This is to Dr. Rasika. When counseling the patients and their families before HACT, how do you counsel them for the possibility of extended transfusion support?
Yeah. As Dr. Rizwan said, the transplant, the course of the transplant actually decides on what would be the requirement of blood support for these patients. So it's very important to prime the family and let them know, because during the transplant period, the families are anyways attending to the patient per se also. And what is important is because you're using a lot of platelets during the transplant period, and the life of the platelets is just 5 days. So many families do have a thought that they can, collect, bank, and keep those platelets, give donations before the start of the transplant, and then use them during the course of the transplant. That is not actually very feasible. So we actually, when we counseling them, we actually let them know that they'll have to spread out their donors across the transplant period. So spread them over a period of say 4 weeks, 2 weeks, and keep some donors who are available at a call away, and get them tested, keep them tested readily available. So, this donor has been screened, and they just call in the donor when there's a requirement, get the platelets collected. And these demands can actually be structured. So, there is a period of thrombocytopenia. So call the donors at their convenience, because when there's an emergency, you can call donors at odd hours, but even donors should not be put to inconvenience. So you can collect a day prior, the requirement is there, collect it, keep it, and then do it, and then spread over the donors. And your platelet donors can be, when you're doing STPs, your donors can be repeated. So you can use the same donor at least twice or thrice during the transplant period. So that also comes very handy for the patient's attendance. So these are the kind of small little things that you have to tell them, or also tell them if things go not the way you're planning, then they would need to identify at least 1 or 2 granulocyte donors where you would need a granulocyte apheresis. So these little things which normally we feel are understood should be actually explained to them, and also so that it doesn't come as a root shock to them.
Thank you, ma'am, for that wonderful explanation. The next question is to Mr. Neeraj. What challenges do patients face in arranging blood products during and after transplant? And this is especially related to smaller cities, and when the patients go to different cities for transplant, not their hometown, they travel somewhere else and they may not have friends and family there. So, in that case.
So I think so. This is the most challenging time for patients who come from smaller cities, or kind of come from smaller places, even to a big city, and where transplants are happening in smaller cities. First, first challenge that they face is language, and because of that, and second is lack of information, because all they know is that the hospital and the hospital's blood bank. They don't know about the other blood banks available in the city, who they can contact, who to reach out to, and stuff like that. So that's always going to be a challenge there. And third, they are not very social media savvy. And I think this is something which has to change over time, where there are several groups on the Facebook where you can actually put a request and immediately you start getting calls from those cities. So I think this is something that I think people have to get used to in terms of arranging blood, because all they have options, because either they're also living somewhere else, they have rented an apartment for BMT, and they're taking care of the patient, they're cooking for the patient, maybe cooking for the family, and then arranging for the blood is a very stressful situation for patients, especially in smaller cities. So this challenge has to be really, if you want to address it at a large scale, at a country level, we need to have a network and a central point from where this information can flow easily. So we need to create this registry of the blood banks and of all the Facebook social media accounts where just one message will get bombarded to everywhere else. So that's really, I think, what we need to do to address this.
Thank you, sir, for that wonderful explanation. The next question is to Mr. Srivatsa Vema. How does Platelet Club help patients and caregivers in ensuring timely access to blood and platelet donors?
As far as platelet club is concerned, as Chennai patients who are getting treatment here in Chennai hospitals, we make immediate family members to donate. So whenever a blood need comes to us, we first ask for patients attender contact. With those attender contact, we talk to them personally. We ask where attenders are working. Chennai is a medical hub, and also we have plenty of MNCs and IT companies. So if they are working in any kind of a TCS or HCL or Cognizant, etc., so these people can easily source donors to their own colleagues and also family. So any blood bank is concerned, they will maintain a minimum required stocks to handle blood emergencies. So once the family is replacing with the sufficient units, hospital blood bank will obviously go and get the units of whatever is required to the patient. People who are coming from outside, we do support from our regular donors and make those family members to donate in their particular place. For example, if a person is coming from Southern North India, West Bengal or Calcutta, we make their family members to donate in Kolkata or wherever they are. So that will help family members to also understand the need and importance of blood donation or platelet donation. So people where they reside and if their hospitals have component donation facility, and if the patient in Chennai requiring SDP or WBC, we make their family members to donate component as well. So this is how we make awareness and create awareness among the patient and attenders to know more about blood and components.
Thank you, sir. Moving on to the next question. This is to Dr. Rizwan. How frequently can eligible donors donate blood and platelets?
Males can donate whole blood every 3 months. Females can donate the whole blood every 4 months. And when it comes to SDPs, single donor platelets can be given at a gap of 48 hours, not more than 4 times in a week and not more than 24 times in a year.
Yeah. Thank you, sir. Moving on to the next question. This is the next slide, please. This is to Dr. Rasika. Dr. Rizwan has already explained, but a very brief answer, ma'am. If patient and blood BMT donors blood groups are different, how do we ensure that proper matched blood products are given to the patients?
So, Dr. Rizwan has actually explained this, that during the pre-transplant and peri-transplant period, you give groups which are compatible to both the donors and the patient. And during the post-transplant, then once the engraftment has occurred, you switch over to the donor blood groups. And I don't think I need to really dwell into it very deeply here, because this has been covered very well. So whatever is given which is compatible to both the donor and the recipient, and we ensure that any issues that are arising because of the preformed antibodies which are there, that do not occur, and all the blood products are irradiated and given.
Thank you, ma'am. The next question is to Mr. Neerath. How does BMT Support Foundation help patients and caregivers in ensuring timely access to blood and platelet donors, sir?
So I'll be very honest here. We have been able to support only Pune and Bombay as of now. but obviously we wish to support. But whenever we get a request, there are four things that we do. The first thing is that reach out to friends and families. Okay. Second is reach out to corporates who have shown interest in kind of donation. And the third is through social media campaigns. These are the only three ways in which we kind of help spread out the message. So that's what BMT Support Foundation does for patients.
Thank you, sir. The next question is to Mr. Srivatsa. Looking ahead, what steps do you think hospitals and NGOs should take to make transfusion support less burdensome for BMT patients and their caregivers?
As far as the hospitals is concerned, every blood bank have counselors and social workers. So we always suggest them to do the basic counseling initially and get required donors from the family side itself if they are from Chennai. When it comes to NGO side, we already formed a common platform under FIBDO, like a Federation of Indian Blood Donor Organization, where we have united NGOs across all districts in Tamil Nadu under one roof, and people who are traveling from different districts to Chennai for treatment. We are supporting them here in Chennai, and as I said before, we are making their family members to donate in their own government hospitals and private hospitals wherever it is. So this is how we are uniting all NGOs together.
Thank you, sir, for that insight. The next question is to Dr. Rizwan. So, when does a patient require granulocyte infusion, and what factors are considered while choosing a suitable donor for granulocytes?
Now, as I mentioned, granulocytes are of two types, buffy coats as well as apheresis. Now, either case, whenever granulocytes are indicated as patients who are having febrile neutropenia not responsive to antibiotics, and could be bacterial or even fungal. So that means the absolute neutrophil count should be less than 500 and they're not responding. And in these cases, given the time span we have for apheresis, you just need one donor whom you could mobilize with the help of dexamethasone, 8 oral tablets, as well as giving 5 micrograms of GCSF subcutaneous injection 12 hours before the collection. And for the buffy codes are concerned, blood center has to be given at least a 24 hours notice so that they can segregate and keep all the buffy codes alive, cross-match all the units, irradiate all the units, label them, and then and should also be group compatible with the patient's group. So that means the same ABOR it should be used mostly.
Thank you, sir. The next question is to Dr. Rasika. Ma'am, is it safe to get repeated blood transfusion? Can too many blood transfusion cause any problems later on?
The blood transfusion that is given, it's ensured that all the blood transfusions are safe. Now, having said that, there are transfusion-associated reactions which are there, which can occur when you're giving too many transfusions. You can have an issue of volume overload, but that is anyways looked after by the transplant physicians. They take care of that. If you're giving lots of red cells, you can have iron overload. Apart from that, your patients can have TAGVHD, that is transfusion-associated graft versus host disease. So there are a lot of transfusion reactions, but they're the same which even the other patients would also face if they're getting repeated transfusions. But the blood banks, the transfusion services and the transplant physicians make sure that, they ensure that these kind of reactions are kept at the minimum, and, proper treatment and everything is in place to make sure that the transfusions do not adversely affect. Yet you can have some issues of alloimmunization, but again, that also can be handled.
Thank you, ma'am. The next question is to Mr. Neerad. What message of reassurance would you give to families who are anxious about the transfusion needs of the patients during the course of BMT?
So I think in today's world, at least we have the advantage of kind of, like the advanced irradiation process. We have the leukodepletion and the other options which are now available that enable that a patient after the transfusion really is able to spring back much faster. So I think given the advantage, a patient is actually in a good state in today's, new age world with these new technologies. And I think they shouldn't be anxious if they really build a community well in advance of people who will stand by them during the transplant. So I think that's the only message that we would give them, to say, you build a community. Like there's a saying that it takes a village to raise a child. Similarly, it takes a city to go through a transplant. So you build your community, reassure yourself, you have the best technologies, the best doctors taking care of you, and hopefully everything should be fine.
Thank you, sir. The next question is to Mr. Srivatsa. Many people are afraid of donating blood and platelets. So, what message would you give to encourage more people to come forward and donate?
The first and the powerful message to encourage blood and platelet donation should focus on two key areas. One is dispelling common fears with clear factual information and emphasizing the profound tangible impact on single donation can have. See, many people find it difficult to donate for their own grandmother or grandfather or mother or father. So we clear those fear and make them to donate first when there is a need for their own relative. So with this, definitely we can clearly bring out all the fear from the people who are not willing to donate blood. And second, the process is extremely safe. First, we need to make this understand. Most of the people, it's only because of this fear, whether is it safe to donate blood. That as an NGO or coordinator, everybody should make donors aware that the process is extremely safe and all the equipments, including the needle, is new, sterile, and also used only once. Is especially for platelets. When the blood goes out and comes back to them after the components are separated, they are much worried whether is it safe for them to donate again and again. We are proud to say that we have donors who have donated more than 350 times of platelets and other components. So all these fear initially they were having, is it safe to donate? But once they started donating, and other point what we make is we make family members to meet the donors every time when they come and donate. So this brings them the confidence. Okay, they wanted to donate more so that more lives can be saved, and also highlight of personal benefits, a free medical checkup. So every time when a donation is happening, they are confidential with their blood pressure, temperature, iron levels, everything is being tested. And also it improves the cardiovascular health. Donating blood may also help the risk of heart disease and also the emotional reward. As I said sometime back, the psychological boost from doing a truly selfless act is immense. Donating can reduce stress, improve your emotional well-being, and also give a sense of purpose and belonging. The final takeaway: the only real cost is small amount of your time. The potential gain is a lifetime for someone else. So don't let fear win. Be a hero today.
Thank you for that wonderful answer, sir. The next questions that we had planned have already been discussed. So this is all from the my end. Over to Dr. Silky.
Thank you so much, Ms. Renal, for excellent moderation and for most importantly for finishing it on time. Thank you all the panelists for taking out time out of your busy schedules and sharing important aspects of blood transfusion during BMT with our audience. And thank you so much, Dr. Rizwan, for our esteemed speaker, for a very informative talk put forth in a very simple language for our audience. And thank you so much to all our audience for listening to us. And I would also like to thank our sponsors, Genova and Novartis, and the ISBMT platform itself, especially Revati ma'am, for being the driving force for these patient support group webinars, and MICE Ideas for providing the technical support for these webinars. And so at the end, I would like to remind you that we will meet again next month. Our webinar would be on aplastic anemia, the role of ATG versus transplant, and this would be on 8th of November. So with this, we close the session. Happy Diwali to all of you and a very happy weekend. See
Thank
you
you.
again next month. Thank you.